If you do see peptic ulcers in kids, almost always, not always, it's Helicobacter pylori. If it's not H. pylori, it's usually secondary to something else. All right? I'm in Memphis. We provide the PGI services to St. Jude's, who has a big brain tumor group. All right? Increased intracranial pressure, we see ulcers from that, and those are Cushing's ulcers. All right? Also, kids with burns will develop Curling's ulcers, and those two have shown up on the boards. Cushing's with increased ICP, Curling's with burns. Do you want my stupid mnemonic device for this one? All right. You guys know what curling is, right? Curling is that sport the Canadians do with the stone on the ice. So Curling's, you need to put some ice on it because it's a burn. Okay, that's the way I remember. Curling's ulcers are from burns because Curling's is done on ice. I've never actually tried it with the brushes and the stones, but anyway, that's the way I remember it. All right, and Cushing's is kind of like Crushing's, and that's pressure, and pressure in the head. I know, it works for me. I'm a gastroenterologist. I look at poop for a living. Let's talk a little bit about Helicobacter pylori, all right, which in my era was Campylobacter, all right, in the old days. You know, Tommy Cross, you know, is an ID guy, you know. I keep asking why they keep changing the name. Well, I think it's just because they have job security if they keep changing the names. Antibody tests. What are antibody tests for? Antibody tests are to tell you that you have antibodies to it, right? If I was to check antibodies for varicella in you guys, how many of you would have antibodies for varicella? Almost all of you. So what does an antibody test for H. pylori tell me? That you've seen H. pylori. Does it tell me you have H. pylori? No. A lot of people have seen H. pylori and they've gotten rid of it. Not everybody that sees it gets it. An antibody test for H. pylori doesn't tell you past or current infection. It's really not all that helpful. I honestly, as a gastroenterologist, never ordered an antibody test for H. pylori. Ever. How do we prove it? Well, there's a couple ways to prove it, but the best way is endoscopy and biopsy and actually seeing it on the pathology. If you do find H. pylori, you do a proton pump inhibitor, you do clethromycin and metronidazole or amoxicillin. Those are that's the primary triple therapy. There's some other alternative protocols for allergies or resistant bugs. How do you follow up? Well, you can get three options. You can do repeat endoscopy. There is a breath test for H. pylori, although the kid has to be able to do the breath test, and that takes a little cognitive ability and skills. Or there is a stool antigen, and the stool antigen is pretty good if you knew they had it and you've treated it. It's not great as a diagnostic. Peptic ulcers use other causes. ZE, Zollinger-Ellison, is very rare. It's a gastrin-secreting tumor. If you find a kid who has peptic ulcer and you find high gastrin levels and you find a gastrinoma, you got to look for MEN, multiple endocrine neoplasia type 1. You've got to evaluate him for that because that's the first thing that should come into your mind. Mastocytosis, you have mast cells that accumulate throughout the body, including the GI tract, and you end up with acid hypersecretion because of the mast cells. I've seen that as well. Oh, this is a beautiful view. This is the Dominican Republic. This is a view looking at, there in the distance is the ocean. Look at that. How many of you would rather be there than in the board review course? Anyway, all right. Malrotation. Okay. Now, this is very important to understand. All right. Our gut grows faster than the rest of our body because it's the most important. Okay. And during embryology, at one point, there's not enough room in the abdominal cavity of the embryo for the gut. So it herniates out into the yolk sac. Now, why is that important? Why is that process important? And then it comes back and it rotates 270 degrees counterclockwise. Now, how many of you, any of you have like an engineering background? How many of you like geometry and those kind of things? All right. If the gut didn't rotate and you had non-rotation, the gut would be on a very narrow pedicle. And because it's narrow, it's going to be longer, and it's going to be very prone to, it's going to be free to rotate. By rotating appropriately the 270 degrees counterclockwise, that puts the gut on a very long, narrow particle on the diagonal, because that's the longest distance. So that diagonal is the longest distance. So the pedicle goes from here to here for the small bowel. And so since it's so long, the pedicle itself ends up being very short, and it's more fixed, so it can't rotate on itself. All right? So it can't turn on its mesentery. So 1 in 6,000 births, though, unfortunately, you don't get the appropriate rotation. The bowel isn't as fixed. The pedicle is longer. It can turn on its mesentery, and you get risk of midgut volvulus. Because when you twist, then you twist off your blood supply. And as I told you earlier, you have to have a blood supply for oxygen. All right? If you have malrotation, you're at risk for volvulus. Most present in the first month of life. 90% will present within the first year of life. Of course, I have actually one time got a phone call about an adult who had gone her whole life with intermittent bouts of very brief abdominal pain, had had an upper GI and was found to have malrotation, had made it to adulthood. The adult GI doc didn't know anything or had no idea about what to do about malrotation. But as a pediatric doc, this lady was in her 40s. All right? So, but that's very unusual. Like I said, 90% by the first year of life. Of course, if you see acute bilious emesis and distension, this is a medical emergency. You got ischemia, bowel can die. This is not a good thing. If you do an upper GI, you'll see the bird's beak after the duodenum, because the duodenum is retroperitoneal. This is a surgical emergency. If it is found incidentally, again, like this lady, correction is recommended. Okay? You are at risk. This is like a time bomb, ticking, you know. And when will it rotate? It will not rotate Monday morning at 8 a.m. Never, right? It will be Saturday night at 8 p.m. An upper GI, the bowel will not cross the midline. The duodenal loop will not go up to the left upper quadrant like it should. This is what you'll see. All right, so here is malrotation. Here's the stomach. Here's the contrast. Goes over, and then the small bowel is on the right side of the belly. All right, so the pedicle is going to be very short. Therefore, it's going to be very long, and it's going to be free to rotate. And this is what can happen. This looks like the Dove. You guys, Dove soap? Looks like the Dove from Dove soap. There's that bird's beak. This is not good. This is a volvulus. This is a surgical emergency. This needs to be untwisted ASAP. All right. You guys ready for another poll question? A healthy 10-month-old presents with abdominal pain, vomiting, and bloody stools. Palpable tube-like mass in the abdomen is present on exam. The appropriate diagnostic study is, read your things, and I will go to the next page. All right. See, I'm watching the numbers and see how many of you actually vote. Ah, very good. All right. So, again, the vignette is to tell you a diagnosis. Hopefully it's obvious. This kid sounds like they have intussusception. Well, so then what's the approach? What do? Well, you want to do something diagnostic and therapeutic. Intussusception occurs usually in the 2-month to 5-year-old age range. The peak is 4 to 10 months. One of the things we're going to go through here, we're going to talk about some different etiologies of bloody stools in kids. All right? One of the keys here is the age of presentation. What age do they present? All right? So, 4 to 10-month-old peak age. So, infancy for intussusception. They have the pain, vomiting, bloody stools, current jelly. The current jelly is because when the bowel telescopes inside of itself, you do compromise the blood supply, so the mucosa gets a little ischemic and will slough, basically. Usually has a lead point of some point. Now, the lead point can just be like a Peyer's patch that's over proliferating because of like a viral illness or something. Of course, there's a lot of lymph tissue in the ileocecal area. That's the reason it likes that area. Juvenile polyps can do it. You can feel that sausage-shaped mass. You can diagnose and treat with the air contrast enema. It will reduce it. If you can't reduce it, then you got to send it to surgery. Recurrence rates are up to 10%. But guess what? That 10% that it recurs, you take them back and do another air contrast enema. Intestinal atresias. 1 in 5,000 births. The duodenum is the most common site of a duodenal atresia. Over 50% are duodenal. Associated with other anomalies, cardiac, GU, anal rectal, esophageal, and obviously you guys all know the association with Down syndrome, right? Down syndrome and duodenal atresia, hand in glove. You see one, you should think about the other. Jejunal and ileal atresias are not associated with other anomalies, and colonic atresia is very rare to be reportable. There's a picture of the double bubble. All right, you got stomach air in the first part of the duodenum, then it doesn't go anywhere. All right, all right. I told you we're going to see a couple of these. 13-month-old presents with several bloody stools. Absolutely no GI symptoms. He is in no distress. Plain films show no obstruction, no ileus. Rectal exam, he has maroon guaiac-positive stool, and the most likely diagnosis is, all right, vote, guys. There you go. Meckel's is the correct answer. All right. Meckel's is an embryologic leftover. It has all 3 intestinal layers. However, 80% of the time it will have ectopic gastric mucosa. Well, what's that make? Acid and pancreatic tissue. It's the most common cause of lower tract bleeding in children because usually the gastric mucosa will ulcerate. You make a diagnosis by a Meckel's scan. You have a tracer that collects in gastric tissue. So you give them the Meckel's, do the Meckel's scan, and you'll see the stomach, and you'll see this little black dot down the right lower quadrant that lights up. It can miss it. It's not a perfect study. The treatment is surgical resection. The rule of 2s for Meckel's. 2% of the population has the Meckel's diverticulum. So in this room, 4 of you probably have a Meckel's diverticulum. Now, if they don't have gastric mucosa, 20% of them don't have gastric mucosa, you can go to your grave with it. It's within 2 feet of the ileocecal valve. It's usually 2 inches long. It's 2 centimeters in diameter. 2-to-1 male to female ratio, and I've never had that adequately explained except the Y chromosome is a deadbeat chromosome. And if it's going to bleed, it usually does so before age 2. Again, because if you have gastric mucosa, it's going to be stimulated. You're going to make acid, so it's going to ulcerate. It's going to bleed. It usually does so by age 2. Again, age hints for the bloody stools. And here's a picture of an actual Meckel's diverticulum. Of course, I will tell you that this is given to me by one of my surgical colleagues, and this one no longer looks like this. It's gone. All right. Duplication cysts. Embryologically, the bowel, when it herniates, is solid. It's a solid core. Otherwise, it would be too floppy to herniate. So it fills in. The mucosa actually fills in. It's a solid core, and it comes back, and then the lumen recanalizes. Embryologically, when the bowel is recanalizing, sometimes something could go wrong, and you get 2 lumens. And again, some of these can have ectopic gastric or pancreatic mucosa. Some of these are in connection with the bowel, some are not, and they're a duplication cyst. They can show up. If they're secretory, though, they'll grow slowly with time. They'll fill up with mucus and fluid, and you'll have a mass effect and obstruction. You can be a lead point for an intussusception. You can have bleeding, perforation, pain if it does have the gastric mucosa. And they're usually found when you do a surgery exploration. This kid has weird pain. It does wake them up. You know, some of those symptoms, you do surgery and you find this duplication cyst. Occasionally you'll see it on ultrasound because they'll be fluid filled. Here's a lumen of the bowel off to your left, and then there's a duplication cyst, a little cyst that when it recanalized, a little area didn't get done recanalizing. Carbohydrate malabsorption. You know, we have 10 to the 12th bacteria that live in our colon. All right? If we don't digest it, they will. All right? But when bacteria ferment things, they make gas. That's one of the byproducts of bacterial fermentation. That's why bread rises. Okay? Anyway, so they also produce acidic components. Well, those acidic components in that gas can cause diarrhea. Sometimes they cause pain. Now, the main milk sugar in human breast milk is lactose. The main milk sugar in kangaroo milk is lactose. The main milk sugar in elephant milk is lactose. Lactose deficiency, or lactase deficiency actually, in infants is very rare because infants are supposed to be breastfed. So, lactase deficiency is very rare until after 2 years of age, the age of weaning. We can actually measure lactase levels by doing a breath hydrogen test or a mucosal biopsy. The most common type of lactase deficiency, obviously, is temporary after a viral illness. You also see some kids who have fructose or sorbitol, very high levels in the fruit juices and soft drinks. When you have overwhelmed the enzyme levels, you end up with malabsorption in the diarrhea because the bacteria will ferment it. The most common disaccharidase deficiency is actually sucrase isomaltase deficiency. That's 5 in 1,000 live births. It's not an autosomal recessive process, and they have trouble with starches. Again, the secondary is the most common type of carbohydrate malabsorption. Here's a few congenital transport defects. I have 2 tables here. Again, kind of the symptom of the defect, A-beta lipoproteinemia. It's a defect in ApoB. You'll have steatorrhea and failure to thrive. Chylomicron retention syndrome, basically, you have trouble getting the chylomicrons out of your enterocytes into your bloodstream. You'll end up, again, with fat malabsorption, failure to thrive. Congenital chloride diarrhea, that's in the colon. You have a difficulty with the chloride bicarbonate exchanger. You have a low pH diarrhea and alkalosis in your bloodstream. Congenital sodium losing diarrhea is a sodium hydrogen exchanger in your colon. You end up with a high pH diarrhea and metabolic acidosis. Hartnep's disease, which is a problem with transporting neutral amino acids, you end up with a pellagra-like syndrome. Blue diaper syndrome, which is the problem with tryptophan. And when the diaper, you get the urine in the diaper and it oxidizes and the diaper will turn blue, that should be, oh, wait a minute, yeah, there's an amino acid transport defect that leads to that. Lowe syndrome, which is not a desire to go shop for hardware. That's a lysine and arginine difficulty, and they'll be mentally retarded. Cataracts and rickets. And acrodermatitis enteropathica is, again, zinc. They have a rash, diarrhea, and failure to thrive. And there's actually an actual disease called acrodermatitis enteropathica where you have a zinc transporter defect. Short gut. Again, we see a lot of kids with short gut syndrome. Necrotizing enterocolitis, volvulus, multiple atresias, gastroschisis. As I like to say to our residents, there are many pathways to short bowel syndrome. All right. Now, when you're short, you're short. But what you lose makes a difference. For instance, your ileum, for instance, is where you tend to absorb B12. And if you lose your ileum, you have problems with B12. Different areas do different things. So, again, your deficiency depends on what you lose. The duodenum, you lose a part of your duodenum, well, that's where you get iron, folate, and calcium absorption. So you see anemia and osteopenia. Ileum, bile salts are recycled there for the intrahepatic circulation, and you vitamin B12. So you see anemia or fat malabsorption. Now, when you're short, the bowel will adapt over time, and the lining will get pressure feed, and you get better absorption with time. So you do get adaptation, so it will get better with time. If you have your ileocecal valve, that's a break. It slows down your transit time, and that will help you as well. You can be shorter and have if you have a valve. The treatment, of course, is adaptation with time, or if you're too short to actually be able to use your gut or have enough gut to use, to transplant your small intestine. If any of you have trained or been at a place that does small bowel transplantation, you know that is no walk in the park or picnic. That is a big deal. Celiac disease. Now, this is extremely common. This disorder is underdiagnosed, and it's basically coming a lot more on the radar because people are becoming more and more aware of it. Gluten, which is in 3 grains, wheat, rye, and barley, actually cross-reacts with human tissue transglutaminase, an enzyme that occurs in our enterocytes. And you end up with an immune reaction, and that immune reaction attacks our enterocytes, and you end up losing your villi. If you're a Northern European, the rate is 1 in 250. Very common. Now we know that there is an association with human leukocyte antigens DQ2 and DQ8. So, if you don't have DQ2 or DQ8, you're not at risk. However, 30% of the population has DQ2 and DQ8. Classic presentation, of course, if you're under 2, You'll see diarrhea, failure to thrive, distension, muscle wasting. We used to talk about these kids who had this huge belly and no butt. They had flat butt. When you get older, the symptoms are not always classic. You see a lot of different things. Again, you can see diarrhea, failure to thrive, distension, muscle wasting, but you can also see kids who just don't go into puberty or short stature. You can see dermatitis hepatiformis. You'll see this characteristic rash on the flexor surfaces. So a lot of presentations. It's associated with autoimmune diseases. In and of itself, it's kind of an allergy, an autoimmune allergy. You see more of it with diabetes, thyroid disease, Sjogren's syndrome, vascular diseases, IgA glomerulonephritis. It's an increased incidence in Down syndrome. It's an increased incidence in IgA deficiency. Screening, there's some antibody testing, IgA endometrial, and the best is the IgA anti-tissue transglutaminase. All right. Unfortunately, this is a higher incidence in IgA deficiency, and so those folks will actually have the characteristic symptoms. You test them, the antibody, and it'll be negative, but then if you measure your IgA level, they don't have an IgA. The classic gold standard is still biopsy. Okay, and on the right here, I have a couple of characteristic pictures. On the right top is normal. These beautiful finger-like villi. They're in the lumen. You know that cheesecake floats by? They grab it all. All right. Now the bottom one, number one, is awful blue, isn't it? There are plenty of lymphocytes in there. And then where are the villi? There are no villi. You don't have any absorptive area. And so the nutrients, they just rush on past. And you never grab them. You miss them as they go by. Microvillus inclusion disease is the number one cause of congenital diarrhea. You see it in it's an autosomal recessive. You do a biopsy, and on electron microscopy, you see microvilli in the inclusions in the apical membrane. Well, the treatment, unfortunately, is parental nutrition or in a small intestinal transplantation. We haven't got a way to make those microvilli pop out. They just get stuck in the inclusions. Other things, tropical sprue. Nobody's quite sure what the pathogen is, but you have to spend at least 3 months in the tropics. You have a severe malabsorption. You do oral antibiotics, nutritional supplements, and it seems to go away. Probably some infectious etiology. I would love to risk it by having to spend at least 3 months in the tropics. Whipple's disease is a very severe malabsorption. You often see arthritis, polypsoritis, CNS symptoms. It's diagnosed by biopsy. It is indeed known to be infectious. And there's you'll see on the screen and in your handouts the name of the bacteria. I'm not going to try to pronounce that. If you want to, don't see me afterwards. See Tommy Cross. All right. All right, colon. All right. What's the colon's main job? Absorb water, right? It's the main job. All right. It's an important job, though. All right. So, two big diseases we really worry about in the colon. One is ulcerative colitis. Now, ulcerative colitis is only the mucosa, so that's a good thing. Okay? But you'll have fever, pain, bloody diarrhea, rash sometimes, clubbing, arthritis. 3% will have primary sclerosing cholangitis, which is not good. How do you make the diagnosis? Endoscopy, which is actually kind of fun, actually. If you become a peds GI specialist, you get to do endoscopy. No cutting or sewing, but endoscopy. P-ANCA positive in 60%. There's an antibody that's associated with ulcerative colitis, although 15% of Crohn's will also have it. There is a colon cancer risk in ulcerative colitis, about 1% risk a year after 10 years of having the disease. Fortunately, we don't see that often in pediatric patients. Crohn's disease is a little different animal. This is like, for a peds GI doctor, this is our cancer diagnosis. This is the worst. Crohn's disease happens anywhere from the mouth to the anus. It is full thickness inflammation, although it loves the ileum best. That watershed area where you switch from your superior to your inferior mesenteric artery, you have some little bit of minor hypoxemia compared to the rest of the bowel. It's correlated with family history. There's a NOD2 gene associated with it. There's several other genes now associated with Crohn's disease. They present how? Well, weight loss, growth failure. Sometimes that's all they have. They have very minor GI symptoms, but they're just not growing. Sometimes they'll have bloody diarrhea. Very, very, very varied presentations. Crohn's is a great mimicker. You have anal fistulas. You have abscesses, all sorts of things. How do you make the diagnosis? You do endoscopy or biopsy. Again, you'll see full thickness inflammation, but the pathognomonic finding is a granuloma. However, that non-caseating granuloma only shows up around 40% of the time. So if you see a granuloma, you're sure what the diagnosis is. If you don't, you have to go with your clinical suspicions. It is helpful. Also, there's an antibody to Saccharomyces cerevisiae that is seen in a lot of Crohn's folks, about 60%. If you get that antibody being positive, that's at least some evidence towards it being Crohn's disease. IBD drugs, how do we treat them? Both ulcerative colitis and Crohn's, in a way, we follow kind of the same pathway. Steroids are kind of our first line. Powerful immunosuppression drugs, horrendous side effects, short-term use. We get it into remission. I tell the kids and the parents, this is how we hammer it. We get you feeling better because most of these kids have been pretty miserable for a while. The 5-aminosalicylic drugs, it's a topical effect. We treat mild to moderate disease with it. Various formulations, and you basically select by the release method. They're released in different ways, different drugs, time-released, pH-dependent coatings, all sorts of different coatings and formulations. 6-mercaptopurine or azathioprine, these are immune modulating drugs. Turn down your immune system without turning it off. This is the way I describe it to the families. It's for moderate to severe disease. Steroid-sparing agents. So get you off steroids. They'll work to control the disease. Methotrexate, again, another immune suppression drug. We use it for moderate to severe disease. It's what we use for the kids who basically have problems with the 6-mercaptopurine or azathioprine. They're the kids who are one of the rare kids who have trouble metabolizing the drugs or something like that. The newer drugs, the infusion drugs that are anti-tumor necrosis factor alpha, infusion drugs, infliximab, adalimumab, certolizumab. You notice the last two letters are AB, which is the abbreviation for antibodies. So these are antibody drugs, is what they are. So they end in AB. There is a system to it. Used for moderate to severe, especially Crohn's, although it's now we also use it for ulcerative colitis. Of course, since it's a protein, you have a risk of an allergy to them. The response, our body does tend to work around it eventually, and the response will fade in some folks. The other interesting thing that we learned with these anti-tumor necrosis factor alpha drugs is that if you had TB, it would reactivate when you use them, which taught us something about TB and controlling TB. The tumor necrosis factor alpha was very important in that. Cyclosporin we hardly use anymore for inflammatory bowel disease. Lots of side effects, although you can monitor levels. Antibiotics we use when there's a fistula, usually very short term. Now, antibiotics are great treatments. They'll work for the inflammatory bowel diseases, but the trouble is they do it by altering your flora. What happens to bacteria when they're exposed to antibiotics continuously, though? They develop resistance, so this effect will fade. So the antibiotics are only used short term. Nutritional therapy, they use it in other countries, but not really in the U.S. Some advocate bowel rests and tube feedings, like an elemental formula in Crohn's disease. You got to make sure you get the vitamin D and the calcium in these folks too, because they tend to have poor absorption of these, and you worry about their calcium and their phosphorus and their vitamin D levels. In the U.S., they don't tend to go for nutritional therapy all that much. Everybody likes their cheeseburger. IBD surgery in Crohn's is reserved for strictures and complications. The disease will recur in the residual bowel. In the old days, they thought they could treat Crohn's by cutting out the disease portion, but you'd cut it out, it'd come back, you'd cut out more, and it used to be the leading cause of short bowel syndrome in older folks out of the infancy age range. Again, got smarter, we've learned that that doesn't help, it's not a good approach. Ulcerative colitis, though, only the colon. You remove the colon, you've cured the disease, quote unquote. And of course, that's recommended if you have dysplasia or you have toxic megacolon, which happens in a small percentage of kids. And nowadays, they have a surgical technique. They create a J pouch or a W pouch. There's a couple different surgeries. They create a new reservoir, a neorectum, with the lower part of the small bowel, which will slow down transit, act as a reservoir to collect the stool. And so the surgery is pretty good. Now, they'll stool a little more than the average person does. It's a big surgery. You don't lightly go into it, but ulcerative colitis, like I said, it's curative to do surgery. Appendicitis, #1 surgical emergency in kids. Present with fever, nausea, vomiting, periumbilical pain initially, then it moves to the right lower quadrant. You have a sudden plane release, that's a bad sign. All of a sudden they feel better. Ooh, that's not good because they probably ruptured, which happens more rapidly in the younger kids. The diagnosis is physical exam, ultrasound, barium minima, it won't fill if it's inflamed, and the CT scan, looking for the changes in the appendix. Typhlitis, patients with reduced immunity, transplant patients, immunodeficiency diseases. Basically, it looks like neck. You'll have inflammation in the cecum, shows pneumatosis intestinalis in the bowel wall. Again, it's treated with bowel rest, IV fluids, and antibiotics. Healthy 4-year-old presents with a history of large amounts of blood with stools, no abdominal pain, has normal growth on physical exam, anus is free of fissures, but the stool is guaiac positive. The most likely diagnosis is, vote, got your keypads? Yeah. There we go. Yep. Juvenile polyp. All right. This is age. Remember I told you age is the key in these bloody stool kind of things. All right. This is an older kid. This is a juvenile polyp. You can see the stalk and kind of a strawberry-looking top of this. 1% of all preschoolers have this. These are inflammatory hamartomas. They're benign. These are thought to be, kind of an inflammatory response, a little hamartomatous area of the bowel lining. They grow very slowly. That's the reason they don't present younger. They kind of present in the preschool age group because they grow very slowly. You have painless rectal bleeding because the surface of them will get irritated. If you have more than 6, you do have to worry about juvenile polyposis coli. That's a long-term risk of malignancy. That's a polyp disorder. You follow them with colonoscopy and remove them is the way you approach the polyp syndromes. Here are quickly a slide about these polyp syndromes. Almost all of them are in this P10 matches category. They're protein tyrosine phosphatase gene errors. And then there's kind of these commonalities to all the polyp syndromes. They tend to have macrocephaly. They're autosomal dominant. They're associated with thyroid disease. They're cancer risk. They're hamartomatous polyps. And they have skin findings. One of my favorites, of course, is Ruvalcaba Meyer-Smith, okay, because they have macrocephaly, but they also have pigmented penile lesions and hamartomatous polyps. Polyps and pigmented penile lesions, Ruvalcaba, okay. Calvin, Banyan-Zona, Banyan-Riley, Ruvalcaba. Again, they have multiple hamartomas of the skin, mucous membranes, breast, and thyroid. Again, they have some other subtle things, but when you start seeing those are the syndromes. And then Proteus syndrome, which is hamartomatous polyps, they have hemihypertrophy. They have giantism of the extremities and angiomas and pigmented nevi. So if you see polyps with hemihypertrophy and some giantism, think Proteus. Peutz-Jeghers syndrome. The gene has been identified for Peutz-Jeghers. It's STK11 gene. They're hamartomatous polyps as well. The big thing with them is the freckling. They have the mucocutaneous hyperpigmentation. They have this freckling of their lips that's very characteristic. They're very high risk for other cancers. Breast, cervix, ovary, testicle, and pancreas cancers, and you got to be aware and you have to follow it. Familial adenomatous polyposis is on chromosome 5q. There's a mutation. This is 1 in 10,000. And most of them are autosomal dominant. They have adenomatous polyps. The most common type of familial adenomatous polyposis is Gardner's. And you'll see these soft tissue tumors with a desmoid, sebaceous, epidermoids, lipomas, fibromas, and osteomas. Kind of a wide range of omas. Other polyps, neurofibromas. You have the cafe au lait spots. You have neurofibromas in the GI tract. 25% of them will have GI tract tumors. The most common malignant tumor of the small intestine is lymphoma. It's usually a Burkitt's. H. pylori is also associated with the gastric malt. Adenocarcinoma in kids is extremely rare. Rare. And usually you have some sort of risk factor. Usually you have familial adenomatous polyposis. You have inflammatory bowel disease. You'll have some sort of a risk factor. Carcinoids are very rare. They're very benign. And they're almost always a tumor in the appendix. We recently had a kid who had an appendectomy and had a carcinoid tumor in the appendix. It was very small, and had no symptoms of it. So that's where they tend to happen. Wall defects on omphalocele, usually at the umbilicus. They're usually bigger than 4 centimeters. They contain solid and the hollow organs. Of course, it's covered by that membrane from the cord. Of course, if you have omphalocele, 75% of them also have other anomalies of some sort. And guess what? All of them have intestinal malrotation. The bowel didn't make it back into the belly. It never rotated. So they're all malrotated. Gastroschisis, it's to the right of the umbilicus, about 2 to 5 centimeters in size. And this intestine ends up short, it's thick, it's inflamed. Again, it's all of them are malrotated. Since this is not covered in any way, this requires emergent surgery to put it back in. The other thing is this bowel, it's shortened for some reason, something about the exposure to the amniotic contents. And it tended to be fairly dysfunctional as well. This is a Dominican Republic traffic jam. Okay. Anal rectal disorders. Embryologically, there's a common cloaca, which is actually Latin for sewer. The sewers ran down the middles of the streets in ancient Rome. I'm a history buff. And then there's this membrane that grows in there to separate the urogenital and the rectum. So, even the top and the bottom, their lungs, the urogenital, the reproductive organs, the urinary tract, the kidney really wants to be part of the GI tract. When the membranes fail to form properly, obviously you end up with all sorts of fistulas and weird things that happen. And of course, as you guys are all aware, males are different than females. All right. Male anal rectal disorders, perianal fistula. There's this tract that empties in front of the anus. Usually, if there's this fistula and the stool comes out this fistula, it's a very short defect. A lot of times they can repair this without a colostomy, primary repair. A lot of times there is an anus there, just that the poop chute didn't make it through it. The urethral fistula, this is actually the most common defect. The rectum and the bladder really didn't separate. The membrane didn't form completely. And so basically the stool empties into your bladder. Not a good thing. Basically this usually requires a colostomy and then later it's repaired. They have to close the common channel and let this heal up. Rectovesicular fistula requires colostomy with later repair as well. Female perianal fistula, it's again in front of the anus, very close to the vulva. Again, a lot of times they can do primary repair and don't have to worry about the ostomy and the colostomy and all that. The vestibular fistula, the rectum empties into the opening of the vagina, into the opening. Basically, this is always pretty much at this point, they repair this with a colostomy and then go back and restructure things. The persistent cloacae, number of terms that have been used for this. Basically, it's just one common open area. The stool, the urine, and the reproductive organs are all in one big opening. Again, colostomy usually, later GI repair, and immediate urologic surgery because of the urinary tract infection risks and all that. This is one of those things where it's like, okay, the reconstruction, all that, you've got to get this fixed. The GI, you can worry about that later. Imperforate anus, the most common is a low problem. Didn't quite get, the poop chute didn't quite make it through the anus. The sphincter's there. You can actually do some stimulation. The surgeons have the stimulators, and they actually see the wink, and they know where it is, and so they can bring the colon through there. The higher it is, of course, the more problematic it is, and the more defects there are, and the trouble is getting that together. Higher incidence of imperforate anus and Down syndrome as well. It's funny, duodenal atresia is well known. People don't seem to be as aware that imperforate anus is also higher in Down syndrome. Rectal atresia is extremely rare, requires a colostomy, and if you can repair later, it depends on if they develop the sphincter or not. If you try to do just an anastomosis to the external skin and you don't have an anal sphincter, you got problems because you stool whenever the stool gets there. Common anal problems, anal fissures, tears of the anal lining from large stools, common cause of blood in the stool in kids. They usually heal. Sometimes they heal and leave a little skin tag. When it heals, it pulls together and you leave a tag. Pruritus ani, those are kids that have dermatitis or some sort of infection in that area. Rectal prolapse. Most common in kids under 2 years of age. Number 1 cause of rectal prolapse is constipation. Number 2 cause is diarrhea. Number 3 cause is cystic fibrosis. Okay? Mucus is thick, it's tenacious. When they try to stool, they have to strain, they get rectal prolapse. Basically, if you see rectal prolapse in kids, most of the time you've got to rule out cystic fibrosis because it's such a common cause of it, number 3 cause of rectal prolapse. Rarely do these kids require any kind of surgical intervention. If you can soften their stools, if they're constipated, if you can get them stooling regularly or get them over their diarrheal illness, the rectal prolapse will fix itself with time. Hirschsprung's. Here's another question for you. This is a plain old know it or not question. All right, no vignette. Hirschsprung's disease is diagnosed by, read your 4 options, and we'll go to the next screen here. Good. See, you guys have a pretty good handle on the GI tract. Yeah, absence of ganglion cells. Delayed new stool passage is a flag that makes you think about Hirschsprung's. Abnormal barium enema suggests Hirschsprung's, but it's not diagnosis. Thickened nerve fibers, well, that could be neuronal dysplasia or some other things. Absence of ganglion cells is the diagnostic finding in Hirschsprung's. 1 in 5,000 births. The failure of the cells from the neural crest to migrate. And basically it migrates, and it's thought to be top to bottom. And the aganglionic bowel stays contracted. It doesn't dilate when the stool comes down. So a rectal suction biopsy will show no ganglion cells. This is what you have to think about in an infant who doesn't stool in the first 48 hours of life. At 2 to 4 weeks of age, because this bowel backs up, the stool backs up, they can develop enterocolitis. And that's a basically life-threatening condition. And the treatment of this is surgical. Here is a barium enema, and you see the transition. The area that is aganglionic doesn't dilate in response to the presence of something in the lumen. All right. Pancreas. All right. Cystic fibrosis is covered by somebody who's a pulmonologist. Okay? Pancreatic insufficiency. Number 2 cause of pancreatic insufficiency after cystic fibrosis is something called Shwachman-Diamond syndrome. It's an autosomal recessive disorder. It's associated with skeletal abnormalities and neutropenia. That's one of them to tuck away. That's common enough to where it has presented itself on examinations. The other one that occasionally will show up as a discriminator question to figure out who the all-stars are is Johansson Blizzard. They're pancreatic insufficient. They have nostril hypoplasia or agenesis. They have a very characteristic facies. They have cardiac hair, deafness, hypothyroid, GU defects, and developmental delay. But the big thing is how their nose looks. At least kind of the clue for you guys. Pearson pancreatic and bone marrow syndrome. Again, pancreatic insufficiency, macrocytic anemia, neutropenia, and thrombocytopenia. It's almost like, it seems like on paper it's like Shwachman-Diamond, just without the skeletal abnormalities. Acute pancreatitis. Etiologies of pancreatitis in kids. Number 1 is trauma. And number 1 form of trauma in kids that leads to pancreatitis is bicycle handlebars. Sudden stop, your belly meets your handlebars, and you end up with pancreatitis. Viruses will do it. Mumps loves the pancreas. Fortunately, we vaccinate for that in these day and age. Drugs will do it, and that's a common one. Several drugs, some of the anti-seizure medications especially will lead to pancreatitis. Multi-system diseases, severe illnesses will lead to pancreatitis, some of the ICU kids, and then there's some anomalies of the pancreas. And the diagnosis, well, clinically, the right placement, the right kind of pain. The amylase, although that can be normal, an elevated lipase. Ultrasound works pretty well to look at the pancreas in kids. Occasionally you can do CT scan. The treatment, we don't have, like infusible anti-pancreatic enzyme drugs at this point. So it's pain control, IV fluids. The key, too, with pancreatitis is, in the old days, we wanted to wait until the pancreas was virtually normal before we started feeding them. Now, what the studies have shown is as soon as the pancreas starts to improve, I didn't say normal, I said as soon as it starts to improve, you start feeding them again, which makes the nutritionist very happy. As soon as they're refeeding, as soon as they're feeling better and the amylase and lipase starting to improve, you start feeding them. Now, you do low fat, you start slow, but you start feeding them as soon as they start to improve. There is some chronic pancreatitis disorders out there, hereditary pancreatitis. They're autosomal dominance, but they have incomplete penetrance. Usually there's a family history of pancreatitis. Mom or an uncle or dad or somebody will have pancreatitis, and 80% of those present before they're 20 years of age in our age group. Sometimes there's defects in some of the enzymes themselves, some of the digestive enzymes. Sometimes there's a difficulty with antitrypsin proteins, which are designed to control and corral the digestive proteins. What's interesting is now they're finding there's some very unique CFTR mutations. They don't have classic cystic fibrosis, but they have a little bit of a mutation in their CFTR gene, and they have pancreatitis, again, because of flow issues in the pancreas. After repeated bouts, of course, they can develop permanent pancreatic insufficiency and diabetes. This is me kissing a baby. I do a lot of that, honestly, when I'm on some of these trips. Congenital liver, we've shifted to the liver. You know, we all love our liver. There must be 50 ways to love your liver. The medicine we charge for, but the jokes are free and worth every penny. Congenital liver anomalies, there's situs inversus. Okay? There's heterotaxia, where your liver can be in the center. Very rare, and almost always associated with other things. What's interesting is the liver cells themselves function pretty normally. Okay? Portal vein anomalies, on the other hand, those are associated with cardiac and urinary tract anomalies. Choledochal cyst, when you start talking about the biliary tree, 1 in 13,000 to 1 in 2 million. So pretty rare. But if you have a problem, you have a choledochal cyst in your biliary tree, you present with fever, nausea, vomiting, pancreatitis, and jaundice. Ultrasound will show this biliary dilation. Choledochal cysts will become cancer eventually. And so basically, if you find a choledochal cyst, you need to surgically intervene. What I find interesting is 1 in 10,000 individuals don't have a gallbladder. 1 in 10,000. Now, it's usually associated with other disorders and other anomalies. What's interesting is hypoplastic gallbladder is even more common. Some people just don't have a gallbladder that's fully developed. The studies, when they've done very careful studies, say that 5% of the population have a floating gallbladder. And it has been described that you can get gallbladder torsion. Anything that can go wrong will go wrong. So there's 5%, your gallbladder floats. Congenital hepatic fibrosis. This is a scary disorder. It's associated with autosomal recessive polycystic kidney disease. And we go back and forth with the kidney doctors because the diagnosis really depends on which one shows up first. Whoever has the first symptoms and sees that specialist first, that's the diagnosis you hang on them. It's a problem with the ductal plates is what it is. And the fibrosis causes basically trouble with blood flow in the liver. Now, so this is in the ductal plates. The liver cells themselves are very normal and work very normal. So what happens is their liver's working fine. They aren't jaundiced. They really don't have any right upper quadrant pain or anything like that. But what happens is because the blood flow in the liver is blocked by this fibrosis, they end up with portal hypertension. And then they develop esophageal varices. But you don't know they're developing esophageal varices. And somewhere, usually in 5 to 13 years of age, they will present with an exsanguinating esophageal variceal bleed. And this kid, as far as the parents knew, was a healthy, normal kid. And unfortunately, I've seen this enough to where it's terrifying. They'll come in and they'll have bleeding from these varices, and they will bleed to 2 or 3 acutely. And it is terrifying. And then what happens is this kid was healthy one day, bleeding the next. You scope them, you band them, you get the varices under control, but then you're like, okay, you have portal hypertension. And then you say, you've got enough portal hypertension, you've got a life-threatening disorder. We need to see if we need to think about liver transplant. And so here's this 5 to 13-year-old that one day is a healthy kid, and then in the span of a short period of time, you're talking about liver transplant. It's a very scary disorder. Very scary disorder. Liver functions are normal because the cells themselves are normal or mildly elevated. If it's severe, you have to think about liver transplant. This is one of those kind of scary, out of the dark. You could have a kid like this floating in your practice, and you'd never know until they present with the bleeding. Kind of like one of those scary tales. Caroli disease is a ductal plate disease. This is an autosomal recessive. You have dilation of the intrahepatic bile ducts. They present with cholangitis. You treat them with antibiotics. If you see it with hepatic fibrosis, it's called Caroli's syndrome. Allen-Giels. Now, one of the things you'll learn, or you guys know, is they're trying to do away with eponyms. All right? When I was young, if you discovered some association or whatever, they would name it, right? And I have been looking my whole career for some association so there could be a Corkin syndrome. You know? Because that's kind of the way to immortality in my mind, was to have a syndrome name for you. But now, they're trying to do away with that because Corkin syndrome doesn't tell you anything about the actual diagnosis. Down syndrome they're trying to do away with. They're trying to call that trisomy 21, which that's actually what it is. It is trisomy 21. Allen-Giels is actually arteriohepatic dysplasia is a better term. It's an autosomal dominant. It's a mutation in the JAG1 homeobox gene, which encodes for the ligand for the Notch receptor. This occurs in 1 in 100,000 births, and these kids have this very characteristic triangular face, kind of a very pointed chin, a broad forehead. When you do a liver biopsy, they have a paucity of bile ducts. And they present as neonates with very profound cholestasis. But they do not have biliary atresia. They have an intact biliary tree. The bile duct problem is in the liver itself. So you don't want to do Kasai on these kids. The cholestasis gets better in most of these kids as they get older. Now, the problem is they also have other things. Okay? They have issues with cardiac difficulties. They can have peripheral pulmonic stenosis, which is the most common cardiac defect. They can also have tetralogy of Fallot. They can have butterfly vertebrae, have abnormal radius and ulna. And most of them have posterior embryonal toxin in their eyes, which doesn't cause them any form of harm, but actually is very diagnostic if you find it for Allen-Giels syndrome, which is arteriohepatic dysplasia. All right, you ready? Here's another common management question. A jaundiced high school student is found to be positive for antihepatitis A, IgM. Who does not need immune globulin prophylaxis? High school classmates, household contacts, sexual contacts, needle-sharing partners. This must be, one of those. Very good. Yep. High school classmates. Hepatitis A is an RNA virus. Fecal-oral transmission incubates over about 15 to 50 days. You're diagnosed by the anti-hepatitis A virus, IgM. Does not come chronic, but 1% can be fulminant. Fulminant liver failure, emergent liver transplant, die from it. You can do IgG prophylaxis. It's recommended for household contacts. Interesting, daycare. In other words, if the kid is small enough to where somebody's having to change their diaper since it's fecal-oral spread. Nursing homes, again, same diaper principle, I think. But not people who work in the hospital, the school contacts, workplace contacts, or day-to-day contact. In other words, the folks who probably not seeing any fecal material. The vaccine is now available and is now recommended. Hepatitis A, I hope, is going to be like hepatitis B that's going to fade away. And we're not going to have to worry about it soon. Again, as a gastroenterologist, the fulminants are scary. When they come in and fulminant failure and, their liver is failing and you have to do emergent listing, not a fun thing. Hepatitis B, this is the only one that's a partial double-stranded DNA virus. And it rides around in serum or blood products. The incubation, unfortunately, is 1 to 6 months. Long incubation. You usually have a prodrome first. Constitutional symptoms, fever, arthritis, urticaria, angioedema. That gets better, then they get jaundiced. Now, if you have to have a suspicion, you can do hepatitis B immune globulin early on. Fortunately, in the U.S., since we vaccinate, again, these are going away. There's a relationship, of course, between the age and becoming chronic. The younger you are, the more likely it is to become chronic. Infants, 90% of them who get hepatitis B will be chronic. 1 to 5-year-olds, 25 to 50. If you get hepatitis B and you're over 5 years of age, only 5%. Less than 1% will become fulminant, but 5 to 7% will become a chronic carrier. Again, chronic hepatitis B, there's basically 3 presentations of it. The folks who are asymptomatic, never knew they had it, don't know they have it, but are hepatitis B positive. The chronic persistent, where they have liver changes, they have some low level, and then they have chronic hepatitis B, where in adulthood they progress to cirrhosis and a very, very, very strong association with hepatocellular cancers. Not good things to have. Again, we vaccinate now, so the kids we worry about this are kids who come from other places who come here. It's like vaccinate, vaccinate, vaccinate. Hepatitis C, now this is the one we don't have a vaccine for. Need one. It's an RNA virus, blood and serum again. Number 1 cause of liver disease and liver transplantation, all comers. All right, not kids, all comers. All right, give you that caveat. But it's the number 1 cause of liver disease. This is a lot of adults. 70 to 80% become chronic. 25% will develop end-stage liver disease after 20 to 25 years. Cirrhosis patients have a very, very high risk for hepatoma. Yeah, as pediatricians, we believe in preventive medicine, preventive disease. We need a vaccine for this. We need some way to prevent it because hepatitis C, 20, 25 years down the road, well, that's after they're out of our age range, but they're going to have significant health effects of hepatitis C. Hepatitis D, again, RNA virus requires hepatitis B to infect. It's no worse than acute hepatitis B if they come together. There's no change in risk of chronic hepatitis B. A superinfection after hepatitis B, however, they tend to become very sick. If you already have hepatitis B and then you get hepatitis D on top of it, you're ICU material. An immunity to hepatitis B obviously makes you immune to hepatitis D. Hepatitis E, this is an RNA virus. Again, it's fecal-oral spread like hepatitis A. Right now, this virus is primarily in the Far East, Africa, and Central America. Trouble is, none of us stay close to home anymore. We travel. The world is very small, very small. And so you can't rule it out. They may have been exposed to somebody who's been traveling. Again, it's like hepatitis A. So they may not, it's not fulminant. They'll get some mild difficulties. The trouble is, the statistics tell us there's a 20% fatality rate from fulminant hepatitis in the 3rd trimester of pregnancy if you contract hepatitis E. Nobody's quite sure why this is. What's the special thing about pregnancy that this virus produces this fulminant hepatitis when you're pregnant? Nobody knows, but it's not a very happy situation. Epstein-Barr virus, infectious mononucleosis. It's a DNA virus spread by infected secretions, usually saliva. Loves the liver a lot. Hepatosplenomegaly can be very big spleens, huge spleens. You'll have mild to moderate enzyme elevations and jaundice. You usually diagnose it, you'll see an elevated IgM. It's usually mild and short, but it actually can be very severe and very long duration. Of course, the immunocompromised folks who get this are at risk of a lymphoproliferative disease when they get Epstein-Barr. This one is, again, something that you see a kid who's jaundiced, you got to think about mononucleosis. Got to look for it. Cytomegalovirus, usually a very mild course. They usually aren't jaundiced. They have mild enzyme elevations. It can be very severe in neonates, however. Very severe. If you do a biopsy, you'll see typical CMV inclusions in the liver cells. Other viruses, any virus, and this is an important take-home point, any virus tends to result in a slight increase in liver enzyme levels. If you do liver functions in a kid with rotavirus, you will see a mild, and I'm talking very mild, increase in their liver functions. We now vaccinate for varicella. Okay, so I don't know. You got your younger generation. You may not see chickenpox like we saw chickenpox in the old days, But we used to see a lot of it. And they'd have, if a kid had chicken pox, you'd take your kids over so they'd get it, and you get it, all your kids, and they'd all get it and get it over with. Okay, that was the way we did it. In the old days, we get 1 or 2 phone calls a year from some pediatrician, well-meaning, who would check labs in a kid who had chicken pox. Now, chicken pox is a systemic infection. And you check liver enzymes in chicken pox, guess what? You can have some elevation of your liver enzymes in chicken pox. And they would call us and they would say, I got this kid, he has chicken pox, he got the rash. And I checked some liver enzymes and they're elevated. It's like, well, it's the chicken pox. Any virus can cause some elevation. So if you have a clear viral illness of some sort and you see some elevation in liver enzymes, almost always it's the liver enzymes are a result of the viral illness that they have at that time. This is me holding a very, very skinny baby. Very skinny baby. I would like to take them all home with me. All right. All right. This syndrome is an important one to know about. It was named by a French physician. All right. The correct pronunciation is Gilbert's. It is not Gilbert's. It is Gilbert's. This is in 2 to 10% of the population. Again, in this room of 280 med study test or future test takers, 280 of you, if it's 10%, 28 of you have Gilbert's. Okay? What is this? This is a defect in the promoter of the bilirubin, uridine diphosphatase, glucuronidase transferase gene. UDP glucuronidase transferase gene. All right? It's in the promoter. The gene itself is fine. So you make a normal functioning enzyme. But you have, because the promoter's there, you don't make quite as much. So what happens is you end up with this mild elevation of your indirect bilirubin. It's usually less than 5. A lot of times it's down incidentally. However, when you become ill or you fast, all of a sudden you become jaundiced. And of course everybody gets really worried and gets bent out of shape. And then what happens is you get over your illness or you eat again and it goes away. It's a benign condition. What really helps is if you talk to the family, it's like, yeah, we had this uncle. Every time he got sick, he'd turn yellow. Usually there's a family history that's very helpful. This is a benign condition. If you find a child, you do some enzymes on them, some lab studies, you have a mild elevation of their indirect bilirubin, and everything else is normal, and they've been healthy and growing and gaining, they probably have Gilbert's. Now, on the other hand, Crigler-Najjar is a complete absence of the UDP glucuronidase transferase gene. You can now do DNA testing for this because this is a defect in the gene. They do not have the ability to conjugate bilirubin. So they have no conjugated bilirubin. These kids either have to be on a lifetime of phototherapy. It works great when they're infants, but when they begin to walk and talk, you can't get them to lay under the lamps. They're too busy. And so they end up with all sorts of issues, and basically you have to consider liver transplant. Nobody's found a way to, get a way around this or create anything because they just can't conjugate it, and that's the way we clear bilirubin. Crigler-Najjar syndrome, which is type 2, is a partial activity of the UDP glucuronidase transferase. The bilirubin is usually less than 10. Doesn't require any specific therapy. No specific therapy has been shown to be helpful, but the partial activity is enough to get you by and keep you out of trouble. Dubin-Johnson syndrome, it's a defect in the CMOT MRP2 gene. That is the transporter, once it's conjugated, to get the bilirubin out of your hepatocytes. All right? So if there's other pathways to get out of the hepatocytes besides the CMOT transporter. So there's other pathways. They're not as efficient, not as effective. So what happens is you end up with this mild conjugated hyperbilirubinate. It's usually 3 to 8, but it eventually does get out, so it doesn't injure the hepatocytes. So, you'll see this elevated conjugated hyperbilirubinemia. The kids are fine, and, most of the time you end up doing a liver biopsy, and it's completely, no inflammation or anything like that. Rye syndrome, we have to mention this, although this is a historical fact at this point. It's an acute liver disease, sky-high ammonias, and encephalopathy. Clotting is way out of line. PT is off the scale, and somehow it was aspirin use after viral infection. At least the studies from looking at some of the tissues from the past, some of the catalog things, looks like it's somehow a viral illness and aspirin causes some sort of a mitochondrial shutdown. And the mitochondria, as you know, is the energy center for the cells. This is mimicked by a lot of metabolic disorders, okay? And they'll have a rise-like syndrome, and they'll present and they'll have this hyperammonemia, and the clotting will be off. And nowadays, if there's no aspirin or anything, it's usually a metabolic disorder of some type. Alpha-1 antitrypsin deficiency, 1 in 2,000 live births, very common. Interesting is that at birth, 10 to 15% of these infants will present with jaundice. Half of them will have elevated liver enzymes. Now, we have these alpha-1 antitrypsins in our bloodstream to deal with the digestive enzymes that get into our bloodstreams, because we all have some that escape. These alpha-1 antitrypsins obviously are resistant to digestion because they're to basically take care of digestive enzymes. If you don't have these anti-digestive enzymes in your bloodstream, however, you can digest things in your body that you don't want digested, primarily the liver and the lungs. Some will do very well. Some of them will progress to liver failure. Some will also develop emphysema. Obviously, we tell these kids, don't smoke. Stay away from cigarettes, because they will break down the lung tissue. You can actually measure alpha-1 antitrypsin levels, affinity type. You can measure it. Usually, most labs will do it pretty quick. You can also do the gene type, and you can do the pi typing, but the quickest way to find out really quickly is just send off an alpha-1 antitrypsin level. Wilson's disease, 1 in 100,000 to 1 in 500,000 births. It's a disease of copper accumulation. Copper is regulated in our body by excretion. We control it really by how we get rid of it, and it's exported out of the liver. Our liver cells kind of store copper. And there's a gene on chromosome 13 that's this export protein for copper. And if there's a defect, then you end up with sky-high copper levels. Now, it accumulates with time, and when it gets high enough, it becomes toxic. The effects are on the liver, the kidney, brain, and the eyes. In the eyes, you'll see these Kaiser-Flasher rings. You can show up with acute or chronic liver disease. If it's mainly brain effects, you have neurologic symptoms. You have acute hemolysis, psychiatric illnesses, behavioral changes, and you thought teenagers were bad anyway. Fanconi syndrome or unexplained bones disease. Screening is ceruloplasmin, although that's not diagnostic. Serum copper or 24-hour urinary copper is also screening. The gold standard is a liver biopsy for copper content. All right, that is a gold standard for Wilson's disease. How do you treat it? Well, you got to get rid of the copper somehow. You got to prevent it from accumulating. What you do is you give them penicillamine, which chelates it, and then it gets rid of it in the kidneys. Then afterwards, after you've treated them, you got it down, you got the copper levels down in their liver, and you're getting it out. You give them a low copper diet, and you supplement zinc, because zinc and copper are transported by the same transporter, so you give them high zinc levels, not as much copper gets transported. Hemochromatosis, excessive iron storage. There's a hereditary hematichromatosis. It's a mutation in the HFE gene. This is an adult disease. Who cares about adults? They're stagnant children. Neonatal hemochromatosis is an acquired disorder. It seems to be due to some sort of severe in utero liver damage. We don't always know what it is. And if they present and they have this neonatal hemochromatosis and massive iron stores in their liver, the mortality is over 90% for these infants. They'll present cholestatic jaundice, coagulopathy that just you can't stop them from bleeding, and they'll have ascites at birth. They're coagulopathic, they're bleeding, and it's bad news. Of course, again, Memphis has a high level of kids who are sickle cell. We see transfusion-induced hemosiderosis. A lot of transfusion-requiring disorders have difficulty with excessive iron in their liver. and there's all sorts of ways that people try to deal with this and get around this. PFIC, progressive familial intrahepatic cholestasis. These are bile transport defects as well, okay? Proteins that get rid of our bile, and there's several different pathways. PFIC1, the old name was bilers. Again, they're getting away from the eponyms. Presents about 3 to 6 months of age. They have a conjugated hyperbilirubinemia and severe, and I mean out of line with everything else, severe unrelenting pruritus. The GGT is normal. There's not a problem with the ducts here. Problems with the transporter. And the thick familial intrahepatic cholestasis gene is on chromosome 18. PFIC2 is another gene, SPGP gene, on chromosome 2. It doesn't have any pancreatitis, doesn't have any diarrhea, prominent liver disease, but again, normal GGT. PFIC3 has cholestasis, has an elevated GGT. The jaundice is less prominent, but the pruritus is still severe. What I can tell you about the progressive familial intrahepatic cholestasis kids is itching. Itching, itching, itching. The liver clears some evil humors. We're not quite sure what it is, but some substances are cleared by the liver that if they're not cleared, you end up with severe pruritus. There is now a gene chip available for neonatal jaundice. This gene chip is a rapid analysis chip for the 5 most common causes of jaundice in neonates. There's intestinal nephrologioles, alpha-1 antitrypsin, and the progressive familial intrahepatic cholestasis disorders, 1 through 3. This will find more than 50% of the cases of neonatal jaundice, which is a great move forward from what we had in the old days. Drug hepatotoxicity, you all know about some of these. Acetaminophen is obviously a big toxin for the liver. Can't tell you how many teenage girls we see who they broke up with their boyfriend, they take a bottle of Tylenol. What's interesting is they feel good, feel miserable initially, then they feel pretty good, and of course what happens is they kill off zone 3, the area of the liver, the hepatocellular area that clears toxins, and then they end up with liver failure and need an emergency transplant. There's an antidote in acetylcysteine which blocks the pathway that produces the toxic metabolites, acetaminophen. Phenytoin, sulfasalazine, and halothane are all hepatotoxic. Antibiotics, erythromycin, trimethoprim sulfamethoxazole. Androgens, some of these adolescent athletes who think they're going to, improve their performance by using some of these steroids. And then oral contraceptives, which are associated with hepatic vein thrombosis or Budd-Chiari syndrome. And actually, it's also associated with adenomas and some of the benign liver tumors. Autoimmune hepatitis. Basically, this is a disorder, fairly common. See it usually in the teenage group. And actually, it's categorized by which antibody is driving the autoimmune hepatitis. Type 1, which is the most common type we see, the antibody is the anti-smooth muscle antibody or an anti-nuclear antibody will be positive. Type 2 is your anti-liver kidney microsomal antibody, and that's type 2. Type 3 is basically adults primarily. It's the anti-soluble liver antigen, and these are available. You send off the testing, and basically if it comes back positive, it tells you it's autoimmune type 1, 2, or 3. Very elevated aminotransferases. What's interesting is as a screen, a lot of times you can send off an IgG level. This is an autoimmune process, and so the body's making all these antibodies against their liver tissues, and the IgG level will be sky high. It's kind of like a crude screen. It's not diagnostic necessarily, but it sure points you that direction. There's usually a family history of autoimmune diseases. Again, you treat it with immune suppression, steroids to kind of get them under control, azathioprine, cyclosporine, tacrolimus to get it under control. Fatty liver, oh my word. This disorder, when I was in training 20 years ago, this didn't exist. And now we have tons of it. These kids who are overweight, the liver is a great storage place for fat. And there's non-alcoholic fatty liver disease, and that's associated with obesity, insulin resistance. The ALT is elevated, out of line with the other liver enzymes. You'll see fatty liver on CT or ultrasound. Most of them are asymptomatic, but some will have pain, which is probably due to some capsular things in the liver. You end up trying to exclude other causes. Some people say you should do a liver biopsy to rule out other things, but if they're grossly overweight and they have characteristic high ALT, it's hard to justify the risk of a liver biopsy. Trouble is, it can progress, and it can progress to non-alcoholic steatohepatitis, or NASH. This is a progression. This is inflammation. This is fibrosis taking place in the liver. You actually start to see fibrosis. They can develop cirrhosis from fatty liver. And now there are actually reports, and we've seen one or two of kids who have come to liver transplant because of fatty liver disease. And they're very high risk because they're so grossly overweight. The treatment, of course, is weight loss and exercise. Easier said than done, though, right? Because these kids are obese for a reason, and there's a lot of multifactorial things with that. What's interesting is some of the studies now coming out say not even cutting back portion size, but exercise will lower some of the liver functions in these kids if you can just get them to exercise. They don't even have to lose weight. Exercise itself will bring it down, which is kind of interesting. Primary sclerosing cholangitis. This is assumed to be autoimmune, although we're not absolutely sure. It's a chronic inflammation leading to fibrosis of the bile ducts. Very high association with inflammatory bowel diseases, especially ulcerative colitis. The diagnosis is by cholangiography, an ERCP. No direct therapies are available for it, although we do chylorrhetic agents. You do the fat-soluble vitamins. Remember, you need the liver flow for fat-soluble vitamin absorption, and liver transplantation if it gets bad enough. Neonatal hepatitis. It's idiopathic. We don't know why it happens. The pathology, if you do a biopsy, these kids will show these multinucleated giant cells. Have very elevated liver enzymes, but a normal GGT. The bilirubin can be elevated up to 3 months. Most resolve spontaneously by 8 months of age. It's some sort of process. Nobody's quite sure what happens, but these kids will be born, these neonates will be jaundiced, and it's neonatal hepatitis, and there's the characteristic pathology. Hopefully we'll figure out someday what the trigger is. Agonist syndrome, again, this is one of those discriminator questions. They want to find out who the all-stars are on the test to ask about Agonist syndrome. It's an autosomal recessive disease, presents in people of Norwegian extraction. They have severe cholestasis and lower extremity lymphedema. My person I did my fellowship under, the division chief, this was his favorite thing. When he wrote a book, he said, I love Agonist syndrome. It's the most fascinating. Anyway, you see a lot of Norwegians in, U.S. All right. 1 month old presents because he has become yellow. They also relate his stools to have become light, while the urine has become dark. Lab studies show the bilirubin, transaminases, and GGT to be elevated. The definitive study for diagnosis is there you go. And that's the right answer. Cholangiogram. This history is leading you towards biliary atresia. This is the #1 cause for pediatric liver transplantation. All right, pediatric, that's the caveat. #1 reason. Are you born with biliary atresia? It's kind of like pyloric stenosis. No, you're not born with it. They've had kids who've had surgery for other reasons or whatever. You're not born with biliary atresia. For some reason, something happens. Is it an infection? There's been all sorts of things associated, and people look for it for years. It comes in clusters. Again, we're not sure what the cause is, but they seem to develop this progressive sclerosis of their biliary tree. It seems to start at the bowel level and work towards the liver. They develop jaundice, usually around a month of age. They'll have these clay-colored stools, and then the bilirubin's coming through the urine, so it gets dark. The GGT, which is a ductal enzyme, is elevated. You do an ultrasound, the gallbladder's atretic. You do a radionuclide scan, you don't see any secretion of the radionuclide through the liver. So that's all well and good, but it's not diagnostic. The definitive test is an intrahepatic or intraoperative cholangiogram. The surgeons take these kids, they will try to run dye through there, and if it's atretic and they can't get dye through, then they do a Kasai. The sooner it's identified, the better, because the less sclerosis has taken place. The treatment is this procedure. They take a loop of bowel up, and they basically attach it to the hilum, create a new drain pipe, I guess, if you want to think of it, for the liver. It delays the need for transplantation, basically because they've created this new drainage conduit, although this sclerosis seems to slow down, but it seems to progress even when you do a Kasai, if it works, still into the liver somehow. Of course, you've taken out the sphincter vodi. It's an open conduit, a loop of bowel. And so there's always a risk for ascending cholangitis in these kids now that they've had a Kasai procedure. And every infection obviously hastens the time when they'll need a transplant. Gallstones, in kids this is very rare. Usually there's a disease that puts them at risk, some sort of hemolytic disease, spherocytosis, sickle cell disease, long-term parental nutrition because you're not stimulating your bowel, short bowel syndrome. Pregnant adolescent girls have a higher risk. What's interesting is since now we do so many ultrasounds in kids, we're finding more and more incidental stones. Several studies now have found that if you have incidental stones, just follow them. Stones found in ultrasound, basically, and they're not any sign at all of any gallbladder disease or liver disease. They're incidental. Watch them. A lot of times they go back and check and they'll be gone. Here is a common bile duct, and there's a stone in it. See the stone in the duct. Cholecystitis is very rare in children, extremely rare. Increased white blood cells, right upper quadrant praying. Mild increases in the liver enzymes and the bilirubin. Usually you evaluate them by the ultrasound. They occur without stones in following a severe illness. Kids who are in the ICUs, kids who have had a burn, kids who have been transplanted. Those kids can develop cholecystitis. They're at risk for it. Gallbladder high drops, this is that list. This is the magic 5. If they give you gallbladder high drops on the exam, think of one of these 5. Kawasaki syndrome, streptococcal pharyngitis, prolonged fasting, prolonged parental nutrition use, or Henoch Schönlein purpura. And when this disease is gone, the high drops goes away. Liver tumors are extremely rare. They're usually in the right lobe. They're usually benign. All sorts of things. Hemangiomas, adenomas, hamartomas, focal nodular hyperplasia. Hepatoblastoma is the most common malignancy in children, usually in infants at birth, sometimes even. Extremely elevated alpha-fetoprotein in the 100,000 range a lot of times. If you can't remove it totally, you have to think about an emergent, quick liver transplantation. And here's a picture of a liver teratoma on a CT scan. And that is it. That is nutrition, GI, and liver. I thank you guys for your attention.